invited to visit Swaziland in early 2005, and to be honest, we had never heard of Swaziland before, and we didn't know what we were really coming to see. And we were at that point exposed to what this one organization was doing in terms of working with the children in the urban areas. It was pretty much a time of being able to be separate from the busyness of life in the U.S. And the 2 weeks here was, Teresa, my wife, went from I will never leave the U.S. to this is where God wants us to be. Teresa was tasked with looking at the health of all of the children and all of the, what they were called neighborhood care points that this organization had. And it was obvious that the health of the children, there was no comparison of the health of the children in the rural and isolated care points versus the urban care points. The health in the urban areas was much, much better. And when you look at it, it primarily comes down to distance to healthcare and the ability to access that, the cost of transport. So in looking at that, we looked at that as an opportunity and a need that had to be met. So we began the CHIPS program for primarily HIV healthcare at the beginning for the children out in those rural, isolated communities. Well, it started out as transport, where we would begin by looking to identify HIV-positive children or potentially HIV-positive children, and bring them into the closest hospital for testing, which is about 25 miles away, 50 kilometers away. And what we found very quickly was that about 5% of the children were actually testing positive, but 50% of the caregivers were testing positive. So we changed the program so it was not just child-based, but child and caregiver. And then we basically managed the access into the healthcare system for that child caregiver, whoever's HIV positive in that group, and provide that transport part. And then over time, pushing more and more services back locally. We had a 13-seater van or combi that was full on every single trip. And to free up space, we had to provide more and more services locally versus relying on the hospital. Okay. Well, because when we first started, we would see numbers of people that were literally on the deathbed. And unfortunately, some did not survive even getting on treatment. Some died right before getting on treatment, but there was many that once they got on treatment with the ARVs for the HIV, recovered fully and were up and working and able to take care of their families. Whereas the alternative was guaranteed that they would have died at some point. And that's partially why we changed from child to child caregiver, because if you don't take care of the caregiver and the caregiver dies, then you're just creating more orphans, which the country already has enough. HIV has changed, and the face of care and treatment has changed over the past 5, 6, 7 years, to where the treatment regimens are easier. People can survive with HIV if they're adherent, if they're taking the drugs like they're supposed to. Once you have this population, which is now HIV is under control, then you start seeing a lot of other diseases that manifest themselves that never would have shown up otherwise, because the person would have been overcome with the AIDS part of HIV. So now you have normal getting old diseases with diabetes, hypertension, whatever those things are, cancers, all those things that you never would have seen otherwise, because honestly people were dying before they ever got to that point. With HIV manageable and under control, then now you're seeing all these other health issues. So the changeover from HIV centered to whole health centered, we were able to accomplish this year, to where we want to be able to go into a community and provide whole health across the board. It doesn't matter, even malaria testing and control as well. We want to be able to provide whatever the health needs are in that community. Well, if you look at the main reason that we actually have to, or there has to be some sort of program or intervention, is because these are impoverished, isolated areas. There is no local economy. So our commitment and what we're trying to do is develop local resources, either personal resources human resources or natural resources that have little or no value in those communities, and develop markets for those skills outside the community, or those resources outside the community. So that we're able to, for example, we have a group of ladies that can sew. Well, if they're sewing within that community, there's really nobody that can able to buy anything that they're making. So we take specific products that are sellable and bring them into Mbaban, or even take them back to the U.S. to resell where there are markets for these products. Local crawfish, out in that part of the country, local crawfish, or imported crawfish really, which are in the waterways there, are not natural and are not part of the diet. People don't recognize them as food, but we can bring them into restaurants here in Mbaban, or we can even look at export markets into South Africa or beyond that. So again, trying to make the connection between resources that have no value to markets where they could actually create a value, to create an economy in that community that people can participate in. The model of what we're doing is being looked at by the Ministry of Health, because they recognize that the availability of health care in the rural areas is a significant and major problem for their goals for HIV intervention, as well as other health care issues as well. So what we would really like to be able to do is continue to expand in the isolated communities that are surrounding where we're already working. Ultimately, we'd like to be able to build a clinic to operate out of in the Mapaveni area, and then also to have a business center and a training center, someplace that we can teach and motivate people from that area on specific skills, and have an operating center from the business standpoint, both for sustainability of a clinic, but also for the skills, and that in itself would generate a significant economy in that area as well. Well, we started out with 2 HIV and testing counselors. We're currently with a nurse and 4 HIV testing counselors that provide the services local in the community, and we'll be adding an additional nurse as a volunteer, again, to be able to provide more of the community health aspect of what we're trying to do. The HIV counselors also double as drivers, for example, in transporting the people into the Good Shepherd, into the hospital system. They do door-to-door outreaches, and we can continue to do that both for like TB screening, but also for malaria screening, for health-related educational issues, going door-to-door into the communities. So we're looking at expanding in terms of additional healthcare skills and what that can do in terms of both in the community. One aspect that we haven't really touched on, but in developing our staff, it's critical for us. Okay, the missionary mentality is when you first come, it's, I'm going to save Swaziland. Well, after a while you realize you're not going to save Swaziland. I'm going to save the Lubombo region. No, I'm not going to save the Lubombo region. I'm going to save Mapaveni. No, I'm not going to save Mapaveni. If I can have impact on our staff, if we can disciple and grow our staff, because we are a faith-based organization, Christ-centered, compassionate care into those communities is what we're trying to provide. So if we can disciple our staff to have them to where they are able to meet both not both, but the physical, the mental, and also the spiritual needs of the people in those communities, being able to pray with someone when there's a need, and being able to provide that aspect of the service as well. So it's not just mechanical, it's not just we provide you with the service, good luck, but to actually be there, create trust and relationship in those communities.